Good morning, everyone. It's my privilege to welcome you to this session of Hopkins at Homewood. I'm Peter Baeff, president of the Johns Hopkins Medicine Alumni Association, member of the School of Medicine's class of 1974, and father of an alumnus of the Krieger School of Arts and Sciences and another alum of the Krieger School in SAIS. Today, we aren't just talking about the future of medicine as some distant concept. We're looking at it in the present tense. We are joined by three distinguished members of the Johns Hopkins community whose work sits at the vital intersection of pure science, bold innovation, and most importantly, direct patient impact. At Johns Hopkins, our mission has always been to bridge the gap between the laboratory and the patient bedside. The innovations you will hear about today represent the next generation of biomedical discovery. These are not just incremental steps, they are transformative leaps in how we understand the human body and how we heal it. Through their work, our speakers are redefining what is possible in clinical care and showcasing why Hopkins remains the global leader in medical innovation. We are honored to have them with us to share their journey from a spark of an idea to a life-changing reality. I would also recommend for anyone in the audience, if they want to learn more about innovation at Hopkins, there are two books I would recommend. Have any of you read The Great Influenza? Nobody. That's a shame. That was required reading during the first Bush administration, and it's a chronicle of the 1917 Great Influenza. The first 75 pages or so are devoted almost exclusively to Johns Hopkins University and the School of Medicine, as well as the Rockefeller, which were the preeminent institutions of science at the time, and I think it's well worth reading. The second book is called The World is Flat. Anybody read that? Friedman, Tom Friedman, yeah. That's a book about us, the United States, competing globally, and a large part of it is devoted to speaking with Bill Brody, who was the former president of the university, as well as Michael Bloomberg, about innovations at Hopkins. We're going to go a little bit out of order today because our first speaker needs to do surgery, and we can't stand in the way of that. Our first speaker is Dr. Charles Della Santina. He is a professor of otolaryngology and biomedical engineering at the Johns Hopkins School of Medicine. He also serves as the director of the Johns Hopkins Vestibular and Neuroengineering Laboratory. His work is a perfect example of the innovation we just discussed. For patients suffering from severe balance loss and often invisible but devastating disability, Dr. Della Santina has pioneered the development of the vestibular implant. Much like a cochlear implant that restores hearing, his groundbreaking technology functions as a pacemaker for the inner ear, restoring the sense of balance and significantly improving the quality of life for patients worldwide. Please join me in welcoming a true visionary in the field of neuroengineering, Dr. Della Santina. Thank you.
Well, thank you very much for the opportunity to speak with you today. I think it's a fascinating topic, and I hope that I can make it accessible to those of you who don't normally think about the vestibular part of your ear. First, I need to disclose that the work I'm talking about today is supported by NIH through NIDCD, NIA, also through Labyrinth Devices, a company I founded, and therefore I have a conflict of interest, and by MedTalks, a cochlear implant manufacturer based in Austria. All the devices that I talked to you about today are approved for use in the US only under the study protocol that we're doing now. And I also want to make sure that I honor the contributions of the individuals who actually acquired the data that I'll talk to you about today, which are almost entirely PhD students in biomedical engineering or medical residents, otolaryngology residents that you see toward the left of the screen with supported faculty you see to the right, and support from engineers at Labyrinth and MedTalks. The man you see on screen now was treated for an abdominal infection. He had peritonitis, treated with gentamicin. He recovered, he survived. He was a little deconditioned when he got out of the hospital. His hearing was fine. But he noticed that he couldn't see clearly whenever he was in a car, and he felt wobbly all the time. And if you look, when his head is quickly moved toward the left, his eyes go off target until he jumps his eyes back on target a tenth of a second later or so. Same thing when you turn him quickly to the right. Off target, jumps back on target. This is the signature sign of bilateral vestibular loss. In this case, a deficit of the fastest reflex in the human body, the vestibulo-ocular reflex, through which, when you turn your head quickly to the left, fluid in your left horizontal semicircular canal stays relatively still, just like if you turn a coffee cup, the coffee doesn't really move. And that then exerts a force on a membrane that pushes on the tips of cells called hair cells that then change the amount of neurotransmitter they release to nearby vestibular afferent neurons, increasing the firing rate of those neurons, and through just a couple of synapses, getting the appropriate constellation of either muscle activity or inhibition to pull the eyes over and keep them on that Earth-fixed target he was supposed to be looking at. Now, meanwhile, just the opposite thing is happening in the other ear because the head is moving away from that ear, and so this hair cell is being bent in the opposite direction, and the firing rate that was non-zero with zero head motion is down modulating. So this is how it works for turning your head side to side, if you're shaking your head no in the US. But you live in a three-dimensional world, so Mother Nature literally went to great lengths to grow your eye muscles around little pulleys when necessary, so that your superior and inferior recti of your left eye, your superior and inferior oblique of your opposite eye are largely being driven by the complementary input from the left anterior and right posterior semicircular canals that act in a tandem pair. And then the third dimension of head movement is sensed in the right anterior, left posterior plane like this by the right anterior and left posterior canals. Now, you all know about the five senses, right? Sight, sound, taste, touch, smell. What about the sixth sense? No one talks about it. In fact, there's a whole movie made about the sixth sense, and it turned out to be the ability to see dead people in the Bruce Willis movie. Maybe your vestibular sensation is not that important. Maybe you can just live without it, and that's why it doesn't even make it into not just individual consciousness, but society's consciousness too. After all, even if you don't have your vestibulo-ocular reflex working for you, you can use other tracking mechanisms, as you are doing right now to read the text on this screen. You can slowly follow the movement of something, and you do fine. So if your head can't stabilize, it's okay. But that fails you during quicker head movements, as when you're riding in a car, right? Now, if I pause this, shake your head side to side, you should still be able to read this. Yes, you can? You can't? If you can't, you have a horrible problem. So unlike a person without vestibular sensation, you probably can keep your eyes stable. You don't even have a concept of what their life is like. But I can tell you, you wouldn't be able to drive safely without this skill. And although I'm going to focus on eye movements and posture and gait, this system is also stabilizing your head relative to the world, not just your eyes, as famously shown by several commercials. Birds do it too.
Upside down. Boy, you turn
Right.
me
Notice how stable that bird's head is? You do the same thing.
round and round.
Right. Now, what we're trying to treat is the loss of the sensation that allows you to keep your eyes and your head and your body and your sense of where you are and where you're going in the world stable. This is often caused by loss of vestibular hair cells. They're much like the hair cells in the cochlea that get so much more press. Sometimes they're due to problems in the nerve or further downstream. In the United States, about a third of these cases are due to gentamicin, like the man I showed you before. About 10% are due to other known causes in the inner ear, but about half are idiopathic at this point. Most of those are probably in the inner ear, but many are central. It causes chronic dizziness, imbalance, difficulty walking, cognitive load, because now you're having to use your conscious thought to avoid falling while walking, which is normally an automatic behavior. It causes shaky vision whenever your head moves, and generally causes a decrease in quality of life. It affects about, on the order of 2 million people, 2 million adults worldwide, on the order of 100,000 people in the US. It creates substantial disability and economic burden, about $18,000 per capita of affected people per year in today's dollars. It often improves, at least partially, with time and with behavioral rehabilitation exercises, but for the people who don't adequately benefit from that, there's really no effective treatment. Our treatment now in my clinic is the same as it was 150 years ago. It's a pep talk and some condolences and telling people to avoid things that make it worse. So to try to address the needs of this population with an unmet need, we've been working now for about 25 years, initially in animals. I won't talk to you about that work today. And since 2014 or 15 in humans, to develop a modified cochlear implant. It's a lot like a cochlear implant with which I'm sure many of you are familiar, but instead of a microphone, we have a motion sensor. Instead of electrodes going into the cochlea and stimulating the cochlear nerve, we have electrodes that are going into the semicircular canals in the anterior, horizontal, and posterior semicircular canal. The motion sensor is outside the body because it consumes a lot of energy. And so it's held on the head in proper orientation by a few extra magnets. Here's a blow-up view of this. We actually have 3 electrodes per canal, which we insert because when we started this work, we couldn't be sure that we were going to get it in the right place. And I'm glad we did that because it turns out that there's always one best electrode, the other 2 are not as good. And when you turn your head in whatever direction, the motion sensor decomposes that into the horizontal LARP and RALP components and then modulates the pulse rate or pulse amplitude accordingly on the 3 channels, stimulating the 3 semicircular canal branches of the implanted ear's vestibular nerve. For those of you who are interested in surgery, this is what the surgery looks like. This is a left mastoidectomy, and so anterior would be the top of the screen. The brain would be toward the right of the screen. This is the back wall of the ear canal. And you can see that we've created a recess under the scalp to put the processor or the receiver stimulator. We might find some anatomy now, find the horizontal semicircular canal, the anterior semicircular canal, the posterior semicircular canal, start making openings into the ampulla of each of them where the nerves enter, and then bring in the electrode array and so forth. Here's a 3D reconstruction. You can see the 3 electrodes in the anterior canal, here the horizontal, the posterior, and here's a return electrode for the current. Here it is in 3-dimensional reconstruction. Now, I won't go through all of this other than to say we first implanted a patient in 2016. It's been 10 years, and it's taken a while. But we first focused on patients who had gentamicin, ototoxic loss, or related aminoglycoside antibiotics. The FDA in 2019 said, yeah, this sounds really interesting. We might consider approving it. However, half the people who have this problem are idiopathic. You need to show that it can work in people with idiopathic loss. So we turned our attention to implanting people with idiopathic loss. Then we realized that no one will get this therapy if we don't get Medicare to approve it, because private insurers only will cover it if Medicare does. And so we turned our attention to implanting older patients so we could get data to support a Medicare case. We had a few hiccups. The COVID pandemic cost us about a year. And honestly, getting a new grant at NIDCD cost us about 2 years because of all the regulatory oversight that accrued. And we've had some screen failures, most often because at least one of the semicircular canals in each ear is still working, and we need to implant all 3. But we've implanted now 23 patients. 5 of them we brought in the hospital overnight, but it was really unnecessary. And so ever since 2019 or so, we've done this all as an outpatient, similar to a cochlear implant surgery. And our patients wear their device every day, all day, 24 hours a day, or during all waking hours, now for up to nearly 10 years of continuous use. Now, a few questions. Can we deliver a sense of head motion? Well, when here patient number 3 puts her device on for the 2nd or 3rd time, you're going to see she's going to respond as though she feels that she's rolling her head and turning her head over to the left. So she's going to put it on, and clearly she feels like she's moving, right? Now, please don't be alarmed, because within about a minute, she's stabilizing. And within about 2 minutes, she's fine. Just like an ice skater who learns how to spin around and then stop and not fall down, with repeated practice, now here on the 3rd attempt of this, you can see that people get better and better at expecting it. And now all of our patients can take their device off and put it on, just like I can take my glasses off and put them back on, and I can quickly adapt to the change in magnification that I see. So you can see now, this is only on in the first 20 minutes of using the device, that by a minute into it, she's fine. Now, can this device drive the vestibulo-ocular reflex, those eye movement stabilizing reflexes I told you about? I can show you a lot of data, but it's easier to just see on screen. If you reach up and wiggle the motion sensor, then you can look at, can you see this? You can move someone's eye. It feels like you're grabbing someone by the eyeballs and just turning the eyes, because the eyes are going to go wherever the system thinks your head is going. So yeah, we can drive vestibulo-ocular reflex in patients who've had gentamicin ototoxic loss. Now, we started with gentamicin because we knew where the lesion was and when the lesion started. In the world of cochlear implantation, I worry about implanting people who've had a deaf ear for more than 15 years, 20 years or so, because we think that central connections may have atrophied by then. So we were curious about people who've had a long time loss, how we would do. So, for instance, this man lost his function while he was a PhD student, 24 years before we met him. And what we see from this is that clearly, vestibular implant can work even after 24 years of loss. So that's great. And in fact, we recently implanted a 72-year-old with congenital hearing and vestibular loss in one ear, and we've got results there too. What about idiopathic patients? Well, the short answer is, yeah, they're doing fine too. And so here's our second patient with idiopathic loss, and that can work there too. Now, I told you I won't drag you through a lot of data, but just to show you some, you can see that as we turn the current up in the channel that's stimulating the horizontal semicircular canal of the implanted ear, we want to see eye movements that are mostly around the axis of that canal. And in fact, here in red and pink for the left and right eyes, respectively, we see a fast eye movement reflex. 100 degrees per second is fast. You don't see much movement in the other canal directions because this should be a response to a horizontal motion. Now, if we instead try to stimulate the left anterior canal, we see in green a movement around the axis of that canal. And if we instead stimulate the left posterior canal, we mostly see a movement around its axis. So we can do this in 3 dimensions. And now I'll fast forward to just recently, how are we doing? Well, on the first 20 patients who are now at least 6 months out, with that test I showed at the very beginning of this, where the man's looking at a spot on the wall and you turn his head, we can measure the performance on that test. It's called the video head impulse test. And what we're seeing is modest, about a 0.15 or so increase in gain, where normal would be getting people up to about 0.6. So we have room to improve for sure. Only a subset of patients get all the way up to normal. But this is similar to the early experience of cochlear implants. People didn't get to 100% speech discrimination in the first years of that either. Now, what about posture and gait? I told you that this doesn't just mess up your vision stabilization, but also your ability to walk. For that, we summarized our results in a New England Journal of Medicine paper I'd point you to. These are an extension of those results, showing that, for instance, on this Brunick-Ozoretsky test, which is kind of standing on one foot, standing with one foot and the other, it's kind of a measures of static balance. You can see that relative to the preoperative baseline, at a half year, at 1 year, at 2 years out, every letter here is one patient, and we see large median improvements relative to the minimally important clinical difference here. And when we put people in placebo mode, then we see that improvement go away. When we turn the device off, then there's a variation, but in the median, they're about the same as pre-op. And I'll focus here on the dynamic gait index. This is 8 different tasks: walking down a hallway, looking left and right, looking up and down, navigating around barriers, walking up and down stairs. You can see that here, again, we have a huge effect size. This is relative to plus or minus 1 minimum clinically important difference here. And we've got a big benefit. That benefit seems to carry over when we turn off the motion modulation or just stimulate it at a constant rate. And I suspect that that's partly because people are just becoming physically more fit after being deconditioned by the loss of their balance function. I think you can more easily see this if you just watch some videos. So I'm going to focus on that for the balance of my time. This is our first patient. He was a marathon runner before he had an ankle injury that exposed the ankle. He was put on gentamicin and lost his balance. You can see now he can perform this task. This is standing with your eyes closed on a thick foam pad. Only about 70% of normal adults can do this at his age. So he's doing well. This is the timed up and go test. Get up out of a chair. Now you'll see as he goes around the corner, he slows just a little, but it looks subtle. You wouldn't notice that he had a deficit pre-op unless you ask him to just turn his head while walking, and he loses balance, what you realize is that he's been relying on his vision and looking at the floor to walk straight. Now, like I told you, he's an athlete. 4 months after his implant, he got back to running on a treadmill for the first time in 4 years. And then he took up boxing and jumping rope. And then he came and jogged around the Inner Harbor with members of our study team. Now, this is his most recent video he sent me 6 years out. I don't think I do these exercises. It's really incredible. And in case you're wondering, yeah, if he takes his device off, no, he can't do any of these things anymore. Patient number 3, you met her before. Here she is pre-op. She heard about patient 1 taking up boxing, so just to show him up, she took up kickboxing. I'm told this is excellent kickboxing form. Now, this is improving people's quality of life. And again, I'll refer you to the New England Journal of Medicine paper. We have some new data coming out soon, but it's not quite out in publication yet. And the upshot is that whether you use a measure of self-reported dizziness handicap or vestibular-related activities of daily living or a general health metric called the SF6 utility, we see an improvement in quality of life. We don't see an improvement when we use a different general health-related metric called the Health Utilities Index 3, and that relates to the fact that it heavily weights hearing outcomes. And as I'll show you, we've had hearing loss in about half these patients. But overall, although the data are noisy, you see here every data point for every person over an 8-year period, and what you want to see is the trends going up toward the top of the plots, and they are. Now, what does quality of life look like just in real daily life at home? Well, I asked everyone to just send me a picture, like what are things you do now that you couldn't do before your implant? And these are sort of examples, getting back to exercising, doing chores around the house, farming or gardening. One of our patients took up bike riding. Walking on a beach is a disaster for people with vestibular loss. It's embarrassing, it's horrible. But getting back to walking out on a beach or walking on a snowy trail, especially touching. Patient 8 told me that his goal of having an implant was to be able to dance with his daughter at her wedding. So, it was touching. Now, I told you about hearing loss. I know it seems startling, but in treating vestibular disorders, hearing is often sacrificed in one ear. Now, the other ear is fine. We leave the other ear alone. But for vestibular schwannoma or for other inner ear tumors or sometimes for vertigo due to Meniere's disease, we sometimes sacrifice the hearing in one ear. Before this work, the only attempts at doing a vestibular implant were done at the same time as a cochlear implant in an already deaf ear. So our trial is unique in that we are implanting people who have a hearing ear, and it's also unique in that we're able to provide outcomes data on hearing as well as long-term stimulation use. In a nutshell, we have a bimodal distribution of outcomes. A little more than half of patients have good hearing after implantation. They have a little bit of a high-frequency hearing loss, probably due to noise during the surgery, but they're doing fine. A little less than half, about 45%, have a large hearing loss, and it isn't yet clear to me why. Clearly, we can achieve vestibular implantation and preserve hearing. We've known for years that we can do cochlear implantation and preserve vestibular function. So I think that we just need to get into the period when many centers, many surgeons are doing many surgeries and will refine technique as we did for cochlear implants. There have been 1 million cochlear implants implanted so far. There have been 23 vestibular implants. But all of those patients, including those with hearing loss, report net benefit. And I'd like to take a few minutes to just have you hear directly from the first person in our trial who had a hearing loss, because patients 1, 2, 3, 4 all had good hearing, so we were feeling pretty good about it. Patient 5 had excellent hearing until about a month post-op. We turned on the device. She had such a strong vertigo percept that she sort of retched a little bit, and she said, I think my hearing just went out. And in fact, she had a perilymphatic fistula event. She lost her hearing. But that means that she's uniquely able to describe the balance between her benefit and her loss. So this will take a few minutes. Oscillopsia is the shakiness of vision with head movement. What's your status now in terms of your oscillopsia?
Very, very mild. It's still there, but nothing compared to it's very, very slow now. Where before, most of the time it was very fast. Now it's very slow. I can read street signs. I could not read the green street sign before, and I can now when I'm riding in a car.
Okay.
And I could not do that.
Are you driving?
Maybe I shouldn't ask. And what's your walking like now?
Much different. It's not perfect. I never thought it would be, but compared to before, it's night and day. I actually relax when I walk. I feel relaxed. You know, when I walk, it's not a complete struggle just to take a step.
Do you use a cane or a walking stick? Or?
No.
Okay. How's your work going?
Much better.
Right.
Much better.
Is there any effect in either direction on your work or your
Oh,
ability
it's
to
much
work?
better. My concentration alone, the fatigue, it's 1,000 times better. I mean, I had to struggle just to get through every day. And by the time I was finished at work, and I worked behind a desk, I was exhausted. There was nothing left.
How's your mood?
Much better.
Okay.
Much better. Everybody, it's funny because most people tell me now that I actually have a smile on my face. I didn't before.
Okay. That's good. Are you still doing rehab-like exercises?
Probably not as much as I should be, but a lot of times I'm so active now that I actually, to be honest, I forget to do them because I guess I forget that there's anything wrong now. I mean, for me, this is incredible.
What's your hearing situation?
It's bad.
Yeah, it's bad. I saw you in your hearing test, actually, it went down a little
Yeah.
further. I'm sorry.
You know what? I knew, and for what I've gotten, I don't care.
Oh, I'm glad to hear that. I care, and I'm
I know.
sorry, and I'm
And-
still
and-
hoping it comes back up.
You know, sorry. I'm sorry, I don't care. I mean, you have no idea what I've gained. None. Just in how I feel about life now. So, it's completely different.
Great.
Sorry.
Knowing everything you know as of today, what would you advise to have an implant or not, and why?
To do it in a minute. It changed my whole life. I mean, I went from barely functional to I could pretty much do whatever I want now.
All right. So where are we now as of April 2026? We have 23 implant recipients. All of them use their system either 24 hours a day, that's 3 or 4 of them, or they take it off when they get in bed at night, like they do their eyeglasses and put it on when they get out, and they're doing fine. Our original FDA authorization said that people could use their implant external device for 8 weeks, and then we had to take it back away from them and follow them for a year. I never understood it, but they said it's what they do with drugs as a sort of a trial and then a washout trial. So our first patient solicited the FDA to ask permission to keep using his device, and they said fine. And our second patient solicited the FDA and asked permission to use it. They said fine. The third patient said, I got fine. So then they approved long-term use for every patient, and they all are using it now for nearly 10 years. We can get a prosthetically evoked vestibular reflex in almost all of the implanted canals. The ones where we don't, we either, I think, broke an electrode or didn't quite get it in the right place. But we have at least one good electrode per canal. As I showed you, we have statistically significant improvements in the median within participant change in video head impulse test gain, in dynamic gait index, the Brunick-Ozoretsky test, test of dynamic visual acuity and road share. I didn't have time to show you, but there are modest improvements there. We see improvements in patient-reported disability and quality of life. 12 out of the 22 ears that started with useful hearing preoperatively still have it, 10 don't. All participants report greater independence in their daily life. Typically, they were brought to their first visits by a family member, and now they travel independently. What's the future? Well, in the last couple of minutes I have, we've done all this work with the Labyrinth Devices MBI, which is the original device that we developed from Labyrinth, which is a company that we created and spun off from Hopkins, in affiliation with MedL, a cochlear implant manufacturer, which we then contracted at Labyrinth to make the implanted part because we don't have a giant factory. Now we're moving toward what will be the long-term commercial version of this device, which will be commercialized by MedL because I'm 60 and we need something that's going to live on long beyond me. And you can see there are a couple of changes. One thing is the original device was not MRI compatible, but the new device has a magnet design that can reorient in an MRI field, which will make it much easier for patients to have MRI. And then the new device is it's smaller, thinner, flatter, lighter. And so here our first patient was very happy when we first gave it to him. What's the future? Well, you can learn a lot about the future of vestibular implantation from the past of cochlear implantation, which started in the 1950s with basic research, in the 70s for initial attempts at the engineering of a device, the 80s of doing the first few implants, the 90s of starting to get real benefit. Our program here at Johns Hopkins was started by John Naparco in 1993 with 2 patients implanted the first time. Now we do about 240 a year. We have about 4,500 patients that we follow with cochlear implants. Bilateral devices, brainstem stimulating devices, very young and very old patients, single-side deafness, all of these, a totally implantable device is the near future, I think, in cochlear implants. I think they're all part of the future of vestibular implants as well. So with that, I'll stop. Thank you. If you have anyone you want to refer to the trial, you can just look up vestibular implant Johns Hopkins and you'll find a pointer to it. Thank you very much.
We just wanted to thank Dr. Della Santini for an excellent, inspiring talk. So once again, excuse me. And now it's my honor to introduce a world-renowned leader in the study of cancer and the biology of aging. Please welcome Dr. Ashani Weeraratna to the stage. She is the E.V. McCollum Professor and Chair of the Department of Biochemistry and Molecular Biology at the Johns Hopkins Bloomberg School of Public Health. She's also a Bloomberg Distinguished Professor and serves as the Associate Director for Laboratory Research at the Sidney Kimmel Comprehensive Cancer Center. Her research is profoundly changing our understanding of melanoma. While much of cancer research focuses solely on the tumor itself, Dr. Weeraratna's work looks at the soil as much as the seed. She explores how the aging microenvironment, specifically how our bodies change, by uncovering how an aging immune system and aging tissues interact with tumor cells. She's paving the way for more effective age-specific therapies. Her work is a vital reminder that to truly treat the disease, we must understand the whole patient. Please join me in welcoming her.
Good morning, everyone. That was a very tough act to follow, but I will do my best. So, as was mentioned, I'm here to talk to you about the intersection between aging and cancer, which is something my lab has been really interested in. And that's because when we look at the rates of cancer, we realize that cancer really is a disease of aging. For every 100 patients diagnosed with cancer, 91 of them will be over the age of 50 years old. And because I'm based in a school of public health, it's incumbent upon me to point out that this is a significant public health burden because we are an aging population. And by 2050, a third of our population will be at this age where people really present with aggressive cancers. So my lab has spent a lot of time trying to understand why this is and why this happens. And the cancer that we have spent a lot of time looking at is a form of very aggressive skin cancer called melanoma. And that cancer grows on your skin. And you might imagine that a tumor that's growing on your skin could be easily extracted by a scalpel, and then everything should be okay. But the problem is that very early on in the life of the tumor, there are cells that escape that primary site and use the blood vessels and the lymphatic system as a highway to go and seed in distal organs. We know that patients over the age of 65 present with metastases far more frequently than patients under the age of 55. And my lab has really been interested in understanding why that is. So what we've observed is that younger patients develop metastases after a much longer time interval than patients who are diagnosed with the disease when they are older. So this graph shows you patients who were diagnosed with the disease under 60 and patients who were diagnosed with the disease over 60. The numbers on the bottom axis, the x-axis, are the number of years after the initial diagnosis of melanoma. And you can see that patients diagnosed early in life take a lot longer to present with metastatic disease. That's also true for other sites of metastases, such as the brain, and we see again that patients under the age of 60 take a longer time to show, for those metastases to show up in these younger patients than they do in the older patients. And we think that that is because when the tumor cells leave that primary site, they do so very early in the history of the disease, and they go to these distant sites and they sleep there for a while. We call this tumor dormancy. And so you can relate this to the myth of Sleeping Beauty, right? So if you all remember your fairy tales, Sleeping Beauty was enchanted. She was protected by this hedge of thorns. I forgot that detail about the fairy tale. And it wasn't until 100 years later where Prince hacked through the hedge of thorns and kissed her that she reawakened and her whole kingdom thrived and grew. Well, it turns out that's kind of what happens with tumor cells as well. They go to these distal sites, they lodge themselves in the lung or the liver or the brain, and then these single tumor cells remain protected by a hedge of normal cells that can keep them in that dormant phase. But as a patient ages, the protective mechanisms that those normal cells have start to break down, and the tumors can then grow. So we have shown that if you take genetically identical cells and you put them in young or aged mice, they will grow, they will migrate to the lungs much faster in the aged mice. And one of the questions we wanted to answer was whether those tumor cells left the skin of the young mice at faster rates, or whether they kind of got to the lungs and then there was this period of dormancy, and I've already given away the answer to that. But this is what we see. So if we implant tumor cells in the skin of young and aged mice, and then we wait 3 weeks and take the lungs, we can look at these little, I guess I'll use the mouse here, but we can look at these little red cells, and we see that at 3 weeks, in both the young and the aged lung, the tumors are growing in these small double or single cell colonies, and there's not much difference in the young or the aged. If we give it just a couple of weeks more, you now see that those red cells have started to grow up very rapidly in the aged lung. And remember, these tumor cells are genetically identical. It's just the cells around them that are different, either aged or young. And so that was really fascinating to us because it told us that that protective hedge around these otherwise dormant tumor cells has started to break down. So we wanted to know what are those reawakening triggers? What is that prince's kiss, if you will, that is waking up these tumor cells? And of course, how can we target that? And so when we look at what these aged normal cells are secreting, we see that if we compare them to young normal cells, the young normal cells are secreting a host of factors that not only keeps the tumor cells from growing, but also it brings in the immune system and has the immune system constantly editing the outgrowth of any of those tumor cells. On the other hand, in the factors that the aged normal cells are secreting are suppressing the immune system and allowing the tumor cells to grow out. So I'll give you an example of one of those. And I don't know how many of you grew up in schools that had nuns or very strict teachers, but really our goal is to be like one of these nuns and stop the prince from kissing the princess in this case. And so this is what we tried to do, and if you told high school me that, I wouldn't have believed you, but I'm trying to act like this nun these days. And what we do is we give these mice these tumors, we give them 3 weeks to that initial dissemination, and then we treat them with antibodies that target some of these growth factors that these normal cells are secreting that allow for the outgrowth of these tumor cells. And when we do that, we can very effectively stop the outgrowth of these large red batches of tumor cells and keep them in these very tiny, sorry, mouse is not really, oh, there we go, and keep them in these very tiny single cells. What we are doing right now is using immunotherapy CAR T cells to also then go ahead and target even those single cells to eliminate them altogether, right? Because while it's great to keep them dormant, we don't know how long we can continue to do that for, and so eliminating them altogether is really our goal. So we were very interested now, so that is what we had discovered in the lung. And lately, we've become very interested in brain metastases because really in melanoma, we can control a lot of the disease, but brain metastases are one of the final frontiers for us, if you will. And just like lung metastases, in the graph, you can see that as patients get older, the frequency of these melanoma brain metastases increases. So we wanted to understand how these cells get to the brain in our young and age patients. We wanted to understand whether there is a dormancy component. Do they get there very early and do they sleep? And how can we target that to disrupt the formation of these brain metastases? And so this is very early work yet, but what we're finding is that cancer cells show very different patterns of colonization. So in the picture on your left that you're looking at, the cancer cells are the bright yellow cells, and the green strands are blood vessels. And you can see that to get into the brain, the cancer cells are wrapping themselves around these blood vessels and moving along the outside of the blood vessels to get into the brain. These particular cancer cells express a specific gene, and cancer cells that don't have the gene can also get into the brain much less effectively, but when they're there, they can grow out into these boluses of metastatic cells in the brain. What was fascinating was when we saw the data, looking at the blood vessels, I said to my student, I wonder if the blood vessels look different in young and age brains. And so she did that, and in these two panels on your left, you can see that the blood vessels are the purple strands that you see, and you can see that these strands look quite intact in the young brain, but in the aged brain, they start to look dotted and broken up. And so when I saw this, I was like, that explains why I can't remember what I came to the grocery store for anymore, right? And it was actually quite startling to see this difference in the vasculature. And this is in the absence of tumor. And now when we put tumor into the skin of these mice, it can further dictate changes in the blood vessels in the brain, so that's super fascinating. We're now using whole brain imaging to go in and look at the brain. These are the blood vessels in the brain. The shadowy bit in the middle is the beginnings of a tumor, and we're now using these techniques to compare between young and age brains and understand how that breakdown of blood vessels is affecting brain metastasis. We can also do this, what we call ex vivo, which is where we take brain slices from young and age mice. We take, again, genetically identical tumor cells. We seed them on the surface of these brain slices and ask, how did they move into the brain slice? When we do that, we see something very striking, which is that in the young brains, this is how the tumor cells will wrap themselves. Again, you're looking at the yellow cells or the tumor cells. The red staining is the blood vessel. And on the top panels, you can see that the tumor cells are basically outlining those blood vessels, right? Whereas in the aged, if there are blood vessels there to co-opt, great, they'll do it, but they don't care. They just invade like crazy into the aged brain slices. So what we are doing right now is dissecting those mechanisms, trying to understand how those tumor cells, how are they different, because they start out genetically identical, but what is changing in the aged microenvironment compared to the young. And we're also really interested in what this whole process of blood vessels and blood vessel breakdown is doing. And that's because tumors really rely on blood vessels. As a tumor grows, it starts to outgrow its nutrient supply, and it's able to send out signals to nearby blood vessels, call them in, and have new blood vessels form inside the tumor, which is one of the most horrifying and fascinating aspects of tumor biology. And so what we found is that tumors in young mice, again, genetically identical tumors, in young mice use very different mechanisms to do that than tumors in aged mice do. And in the young mice, we see that those tumor cells secrete a factor called vascular endothelial growth factor. But the same tumors in aged mice do not secrete that factor anymore. So these panels that you're looking at, the brown staining is for vascular endothelial factor, and you can see that in the aged mice, they don't secrete that. Instead, they start to secrete a different molecule called SFRP2, which is also very proangiogenic. It makes a lot of these blood vessels, but it also explains to us why in the clinic, molecules that are designed to inhibit angiogenesis have all been designed against VEGF. And so if most patients are older, and if most patients have stopped making VEGF, then those inhibitors against VEGF are not going to be as effective. And so we really need, this is another reason why it's so important to understand what's happening in the patient system as a whole. Here's another example of a factor that we know divides whether or not a patient is going to survive their brain metastasis. Again, it's a factor that has nothing to do with tumors in general. This is a neurotropic growth factor. And we can see that when patients have more of this receptor, they're more likely to metastasize to the brain and less likely to survive their disease. And so we're looking at this as a potential target to disrupt these brain metastases as well. So I hope I've convinced you that cancer is a disease of aging. Over the years, we've learned that it impacts everything from the biophysical matrices on which tumor cells sit to their ability to undergo this process that I just described called angiogenesis. The metabolism of tumor cells is completely different depending on what environment they find themselves in, and metastasis is altered as we age as well. But it's not just age, it's also sex, and we've recently published that men and women age very differently in their normal cells, specifically in a cell type that we call fibroblasts. And because they age differently, we find that older men are less responsive to targeted therapy in melanoma, and their tumors are more aggressive. And so this was also a fascinating finding, and it really brings to mind that, again, we can't just study the tumor cell. We need to understand the ecosystem in which it exists and how that ecosystem changes with time, with biological sex, with other macro-environmental influences as well. So I get to come here and talk to all of you wonderful people, but these are the people who actually do the work, my incredible students. I came to Hopkins about 7 years ago now, and I've just been blown away with the quality of the trainees and the students, everyone from undergrads all the way through to oncology fellows. The collaborations at Hopkins are superlative. I have amazing collaborators here. And then, of course, cancer is a global disease, so we have lots of collaborations across the street, across the country, across the world. And I'll end, as I always do, with my favorite aging study, who's my daughter. And I only have one child, so that's why she's my favorite. Thank you so much.
Well, that was an excellent talk. It also reminded me, I spoke with Dr. Weeraratna before the meeting began about a patient of mine that I've seen for about 15 years who had myeloma, an older man who's now 80, who had myeloma and then developed a periorbital melanoma and was treated with immunotherapy with ipilimumab and nivolumab at Memorial Sloan Kettering in New York City. And he developed a reaction to it and only received 6 months of therapy, and that was about 6 years ago, and he has no evidence of disease. I thought he was going to die. His tumor was about 2 millimeters from his brain. He was seeing double, and it's absolutely amazing. So once again, thank you for an excellent talk. I'd like to now introduce our final speaker, who is Dr. Cheol, who is an associate professor of surgery, pediatrics, and biomedical engineering at the Johns Hopkins School of Medicine, and also serves as the director of research at the Blaylock Taussig Thomas Pediatric and Congenital Heart Center at Johns Hopkins. His research addresses one of the most critical challenges in cardiology, the limitations of mechanical pacemakers. While life-saving, these devices require surgery, batteries, and lead wires. Dr. Cheol's groundbreaking work focuses on biological pacemakers, using gene and cell therapy to reprogram ordinary heart muscle cells into specialized pacemaker cells. Essentially, he is teaching the heart how to heal itself from within, creating a natural biological alternative to electronic hardware. This work represents a massive shift in how we treat rhythm disorders and stands at the very forefront of cardiovascular innovation. It's an honor to have him here. Please welcome Dr. Cheol.
Thank you so much. It's my incredible honor to be here and super excited. Essentially, this is the pacemaker that's going into the patients today with a wire hooked up to the pacemaker. What we want to do, what we aspire to do, is to create a pacemaker that you no longer can see with the biology that we're all born with. I founded a company. I need to remember that I bring it back to the lab because we need it for large animal studies. I founded a company called Intrain Bio in November last year. The company has no funding, no scientists, but the aspiration is really high. It resides in a corner of a basement in my home in Howard County. Some of the things that I'll be sharing with you has a pipeline that we will plan to license to Intrain Bio. In the next 25 minutes, I'll cover what is the pacemaker, what is the problem, is there a problem that we can solve? And in the second section, I'll show you the biology of how to reprogram, how to instruct our own heart muscle to become pacemaker cells. And then in the last part, I'll talk to you about our earnest effort to restore the rhythm with our biological therapy. What is the problem? Well, there are two different ways to look at the heart. One as from a plumber's perspective or from an electrician's perspective. A plumber will say the heart needs to pump and we need to have the blood to go through our whole body with each heartbeat. But that heartbeat cannot happen without an electricity. And the heart has a small electrical generator that runs by itself. It's on nature's one of the most advanced autonomous vehicle. And that pacemaker resides at the top back of the heart, at the right atrium, and that's called sinus node or sinoatrial node right there. Electricity spreads around the atria and then arrives at another node called atrioventricular node, and then it's an autobahn. It flows through really fast. As soon as the electricity flows, it excites the heart muscle, heart contracts, and we have a heartbeat. When it doesn't go very well, and when our heart rate is too slow, then we have to have a pacemaker implanted. Usually, our cardiologists will make a small pocket in the right chest and implant this, and then navigate the wire through the vein, and the wire goes inside the heart and screws onto the heart muscle. At its most simplest concept, it's basically shocking the heart with electricity. 80% of this thing is a battery. I have to say, because maybe this talk will be viewed by Medtronic and St. Jude and Boston Scientific, that pacemakers save a lot of our lives. It works well, but is it perfect? There are limitations. The conventional transvenous pacemakers has a generator and a lead, and generators can fail, leads can break. Even if they work the way they're intended, delivering about 10 to 20 times higher electricity to the heart with a metal causes problems, and you have to juice up the electricity as the time goes. And there is something called pacemaker syndrome, that this pacing is not natural, and then the heart swells and cardiomyopathy happens. With the wire inside the blood vessel, there is a lot of vascular problems that can happen. In the past 10 years, this smaller pacemaker called leadless pacemakers have been developed and marketed. It goes into patients for those who have supposedly a little shorter horizon for pacing, because once the leadless pacemaker goes inside the heart, it's got no lead, but the whole thing needs to go in to pace the heart. Taking it out is a problem. All these problems is not enough to stop the industry. So there are about 1 million people every year in the world getting the pacemakers implanted. It fuels about $5 billion industry. It still requires lifelong commitment to repeated procedures, device replacements, and risk of complications, including infection. 1 in 20 patients who get a pacemaker implant will develop an infection within the first 3 years. And infection is a problem because when a pacemaker, either the pocket or the lead is infected, you have to take the whole thing out. And how do I get the pacing? You have to get an external pacemaker taped on your chest until you get the infection treated. So it is, we believe, the argument is strong that the current clinical treatment for bradycardia, slow heart rhythm, has diminishing clinical return, which gets amplified in the pediatric setting. You're looking at a 2.5-year-old boy. And for congenital heart disease where the heart rate is too small, well, we'll have to crack the chest open, run the wires, attach the wires on the heart surface, and then the generator goes inside the abdominal space. You can see that there's a lot of wire. Baby grows, wires don't stretch, so we have to put extra wires there. But wires get tissue adhesion, so it is not uncommon to get multiple surgeries within the first decade of the life to either replace or reposition the hardware. Now, it's ironic that now we have more adults living with congenital heart disease than kids, because the surgery and the care has been much better, and the decades-long pacing horizon is expected for our patients. So the current solution is far from ideal, often inadequate. How can we regenerate the pacemaker cells that we're born with? Well, the benchmarking is the one that we have, the sinus atrial node, or SA node. It is a very small thing. Our heart is about this big. Sinus node is maybe 1/4 of an inch. The pacemaker cells that you and I are born with are less than 100,000 cells, and those cells sort of stay with us for our lifetime. It's incredible. The cells look kind of different, and it's, again, autonomous driver. The last point here, it responds to autonomic input. Our heart rate can accelerate or slow down depending on the need. If we watch our favorite sports team winning a game or pennant, our heart rate will increase. We're not doing anything. We're sitting on the couch and watching the TV, but the heart rate increases because it can respond to emotion, and I'll touch upon that later. The reprogramming concept is born in a way that we wondered. We went into electronic library and read a lot of papers, and we saw this was about 15 years ago, and realized, the heart is a complex organ, but the pacemaker that we are born with has about a dozen or less than a dozen important genes that are really needed to make it from the first place. And one of the genes is called TBX18. It's called a transcription factor, and transcription factor is a switch. It turns on and off other genes. And the concept is we're all born with a single cell, or we started with a single cell. And that cell needs to make a decision along the embryonic timeline to become heart cells, eye cells, ear cells, or any other cells. About 15 years ago, somebody developed a technology to take your skin fibroblasts and make a stem cell that can, again, give rise to brain cells and heart cells. What we thought about was, well, can we take terminally differentiated heart muscle cells into pacemaker cells that we're born with? And that is a concept of direct reprogramming. And we studied a lot. other people's work, and that's what all science is all about. We learn first. And we learned that there are, again, a handful of genes that are so important, and TBOX18 is one of them. If you knock out in mouse life both copies of that gene, TBOX18, about 70 to 80% of our pacemaker tissue never develops. We looked at other genes too. And then here is one experiment, and we took that idea. Again, we start with heart muscle cells, and then we add the gene, and we want to see whether the muscle cells will begin to beat there. We added a gene called GFP. It's called green fluorescent protein. It's from a jellyfish, and that's why jellyfish glows in dark. It has nothing to do with our heart. So we added GFP gene, and some of the flashes you see here and there is a marker of cells beating. So we used a dye that will report to us about the cells beating. And in this placebo, we don't see much. When we added TBOX18, we saw fireworks. And that was very surprising because when we started this study, we thought we'll probably have to add TBOX18, TBOX3, SHOX2, all kinds of other genes, but TBOX18 turns out to be a big X. We took that gene, injected into small mice and rats directly into the heart, and green cells that you see are the cells that took up TBOX18. We isolated with these ones, and then we did something called patch clamp, which is, you can think of it as ECG on each cell. So, I'm sorry, before we get there, when we deliver this TBOX18 to the heart muscle cells, they actually change their shape. And on your left, the red stain is all muscle cells in the cardiomyocytes. When we added TBOX18, the cells sort of lost some weight, became squiggly. And when we looked at the gold standard, these are pacemaker cells from the sinus node, the real ones, they look pretty similar. And then, this is the ECG in a dish. We poke the cells with the electrode and measure their membrane potential. What that means is when, again, pacemaker cells are electrical generator, so they fire electricity regularly. The heart muscle cells stay pretty flat. They don't fire anything until we actually artificially trigger it. The myocytes from the ventricle, when we added TBOX18, started showing spontaneous oscillations that looked like, again, the gold standard, the pacemaker cells from the sinus node. This looks kind of boring, but I grew up as a patch clamper. When we first saw this data, I could not contain my excitement. This is EKG. This is a guinea pig experiment and rat experiments where we tested our concept in small animals. We created a disease model. We first burned an AV node. The sinus rhythm from these animals is fine, but the ventricles, the big muscular part of the heart, is not getting any signal because the bridge is burnt, electrical bridge. And then we injected our gene, either placebo or TBOX18. And TBOX18 injected animals showed faster heart rate, as you can see in these downward spikes. And there is some more information in this EKG that I don't think I'll explain today, and because I want to go to the large animal studies. I had some inkling of telling you all the studies that we did and what it means, but let me just summarize all these things to tell you that we learned a lot about the mechanism. And one of the things that we realized is that this gene goes in, you don't need this TBOX18 gene for weeks and months. The reprogramming happens within the first 1 week to convert muscle cells into pacemaker cells. So, with that excitement and understanding, we made a therapeutic development of the biological pacemaker that we called BioPace. Messenger RNA. This is, the biology 101 is we have DNA, we have protein, but in between the two, we have messenger RNA as a middleman. And messenger RNA got a lot of publicity from the vaccine. And the thing about messenger RNA is it doesn't last very long. and it degrades very fast, and you inject it, maybe it will last about a week. That time frame is pretty good for our reprogramming process because we understood from the biology that the reprogramming doesn't need this gene too long. So we took the messenger RNA and tried it. First of all, we wanted to deliver into the heart and see whether we get any expression. We took the jellyfish gene, again, the placebo, we put it into the syringe and injected it into rat heart. So it was a direct focal injection into the beating heart. We let the animal live for about a day or two, and then we bring the animal again, we harvest the heart, and we look at the injection site, and lo and behold, we actually see mRNA for the GFP gene expressing green things in our heart muscle. What that shows is that it works. The mRNA can go into the heart muscle and make the gene that you want. A little busy here, all this data to show that expression profile of this mRNA lasts about a week, 7 days. When we looked at this spillover, we are injecting into the heart. We don't want this thing to go to the brain, lungs, kidneys, pancreas. The spillover is much lower. This is the intended heart, and liver, lung, spleen, kidney, and intestine expression is much lower with mRNA when we compare to the viral vector that almost all gene therapy field uses. So the safety profile, again, is better. Here's the pivotal study. We set up a cath lab. It's exactly the same as how I would get treated if I have a pacemaker implant procedure needed. The only difference is here is the patient is not a human, it's a pig, a full-grown pig. The pivotal study was a biopace, which is TBOS18, mRNA gene therapy, and because we go in with a needle and inject this, there's some fibrous inflammation, so we wanted to tail it down. So we used a TGF-beta inhibitor to tame down the fibrosis. Now, the procedure has 3 steps. The first step was to implant the pig with a pacemaker. And then the lead goes in, the lead wire goes into the right side of the heart into the ventricle and gets screwed onto the heart muscle the way that a lot of patients get. That's number 1. Why? Because after we set up the pacemaker, we're going to burn the AV node the way that a lot of tachycardia patients get the ablation. As soon as we burn the AV node, the pig's heart rate goes from about 70 beats per minute to below 50, 55, and we may lose the pig on the table. So what we do is we program the pacemaker at a slow rate so that if the heart rate goes too slow, the device will kick in and keep the pig alive. And then we change the catheter, we inject it into this bundle called HIS bundle. And again, that's the autobahn, that's the electrical wiring. So to create the biological pacemaker, we're using the heart's natural electrical wiring. And that's the pacemaker lead. This is the injection catheter. And maybe with a sprinkle of imagination, you will see a shadow getting injected. And that shadow is right there. So that's the gene injected. Simple graph, but very exciting. Control placebo injected pig. Heart rate over 3 days, 72 hours. Paced by the backup device. If we didn't have a backup pacemaker device, we'll lose the pig. The TBOS18 injected pig, sometime in the morning, the heart rate goes up. And then most of the morning, early afternoon, and then the heart rate slows down. The next day, it does the same thing. The next day, it does the same thing. When we first saw that data, it was around 9:10 p.m., real time. We got excited. Number 1, it's working. Number 2, what's happening in the morning? We called the animal facility. Are you guys like playing with a pig? What we learned was for this cohort of pigs in that animal facility, the pigs were fed only once a day around 8 or 9 a.m. Now, these pigs are housed not only in big C-suite, it's a small quarters, so they can walk around a little bit, but pigs are not known to be great exercisers. You walk in at 8 a.m. in the morning when they feed the pig, you cannot walk in without going like this because they get so excited to see the food and they scream. It's the emotion of seeing the food and getting the food and eating it shoots up their heart rate. Motion cannot do that. So those two things really got us excited. And we followed these pigs for about a month. Every morning, every day, it goes up. This is mean heart rate. This is maximum heart rate. Wow. We also wanted to see how the patient is feeling. And one way to ask how the pigs are feeling is to see whether they do walk around a little bit. So this was all ECG, 24/7 telemetry ECG recording in the previous figure and this figure as well. And when they walk around, that telemetry device has an accelerometer, so it can measure the steps. This is a snapshot of their activity and heart rate at day 15, midpoint of the study. Let's see, heart rate is the solid line. Activity is the dotted line. Whenever activity goes up, the heart rate matches. Placebo pig, heart rate flat, activity low. Proves two things. Biological pacemaker can keep up with exercise. And number two, the patients feel good enough that they move along more. The last slide on this pig study is to see, does the pacing really come from where we injected? Day 1, day 14, placebo-injected pigs, the pacing all comes from the bottom of the heart where the backup pacemaker was implanted. At day 1, sure, the T-box 18 injected pigs were paced by the backup pacer, but at day 14 it comes from the side of the heart where the his bundle, the injection site was. So what do we have? We have a biopace. It's a non-viral, non-integrating, so it doesn't modify your genome. A brief time frame mRNA gene therapy, it's a natural gene that we're all born with. T-box 18, sorry that I didn't mention this. Again, it's a gene that it's a master regulator for our sinus node, but just before we are born, it goes away. What we are doing is to reintroduce into the heart muscle so that some of these heart muscle cells become pacemaker cells and creates natural heart rhythm at the injection site. What are the next steps? We're incredibly excited working with our pediatric cardiologists and our adult cardiologists. The clinical translation is within our horizon. We want to optimize the delivery method, make this mRNA encapsulated in things called lipid nanoparticle. It makes mRNA to get in a lot more efficiently, in our hands, about 157 times more higher. Validate durability, efficacy, and safety in a larger cohort of a large animal. We have already engaged with the FDA for our first regulatory meeting 2 months ago, and the enthusiasm is very high. First in human, I mentioned the pediatric patients being, we believe, the largest clinical impact can be made, but the first in human study will likely be with those with a sinus node dysfunction or sick sinus syndrome. Relatively healthy. The only problem that I have is sort of slow heart rate. I have a pacemaker. The pacemaker doesn't work all the time. It just keeps me feel good enough. Now, the case numbers in our country alone, 78,000 new cases of sick sinus syndrome needing a pacemaker. New cases by year 2060, about 172. In 10 years, cumulative volume is going to be more than 1 million patients. We'll take biopace as a primary therapy and keep the device as a backup. That way, the safety profile will be as high as we can achieve. And one more thing. I put this in about 4 days ago. the funding, the research and development landscape in the past few years have been a little rocky and more challenging than we hoped. And it reminded me of this famous quote that, of course, he didn't say about himself. He said it to his opponents, that everyone has a plan until they get punched in the... We thought, okay, this is not easy, the research development and especially federal funding landscape is not easy. What would you do? There are many different ways to respond to that. We responded by doubling down. We thought, okay, this is time to develop not only the things that we already have a horizon for clinical translation, but something even more innovative. What would that be? When you look at the heart as an organ, I mentioned the sinus node is an autonomous driver. It's an organoid. It's a miniaturized organ. So we go back to the cartoon published in 1957. Going back to the stem cell part, we thought, well, we have the technology. It takes, literally, you take a skin biopsy, and within about 3 to 4 months, you will have your own induced pluripotent stem cells that can give rise to many, many body parts. We're building human SI node organoids. And this incredibly talented fellow, Misato Nakanishi Kwakutsu, now being promoted to our early faculty, has developed a pipeline where you start with these stem cells and convince these stem cells to become cardiac, but more of a pacemaker cell, and make organoids out of them. And you can make a variety of different organoids that can be adult patient rate-tuned or pediatric patient rate-tuned. We think that this platform can only be a therapeutic platform, but also could be a drug discovery platform, because when we do drug discovery and every single drug needs to have cardiac toxicity screen, there's no platform that tests for our heart rhythm, and our pacemaker organoids can serve as a pipeline. This is the second last slide. The reason why I'm so incredibly excited is I'm speaking here, but I'm one of you. I should be sitting there because I did my fellowship training at Hopkins, left and came back 3 years ago. When we look at the history of cardiac pacing, started with external pacing in 1950s. In the 70s and 80s, there was the first implantable pacemaker, and Hopkins had innovations going into the technology. Dr. Michel Mirowski and his scientific partner, Morton Morrow, developed cardiac implantable defibrillator with a battery-driven. And that technology was incredibly helpful for the pacemaker as well. And Hopkins Applied Physics Lab, APL, had their engineering expertise going into the pacemaker technology as well. Now we've got leadless pacing. We believe the next and the future cardiac pacing will have Hopkins fingerprints all over for the paradigm-changing therapy. The most important part, I'm a cheerleader for all these incredibly talented and devoted scientists that have been pursuing this dream. I wanted to single out Dr. Myron Weisfeld, who was a Department of Medicine chair, and he's sort of our advisor at large, giving us a lot of indications and directions for clinical trial and connecting us to the right people so that we can pursue this dream. Thank you so much for your attention.
Thanks. So Dr. Cho is our last speaker. Let's all give him one last round of applause for a very interesting talk. What we have heard today is a powerful testament to the Hopkins way. whether it's restoring a sense of balance, reprogramming the heart to heal itself, or understanding the complex landscape of an aging body. These researchers are doing more than just studying disease. They are reimagining what it means to live a healthy life. Each of these breakthroughs started as a question in a lab right here at Hopkins. Because of their dedication and the support of our alumni and donor community, those questions have turned into solutions that are changing lives around the world. Thank you all for joining us for this engaging discussion. We look forward to seeing the continued impact of their incredible work. Please enjoy the rest of this day. Thank you very much.